Good morning, everybody. It is my distinct pleasure to introduce today's Grand Round speaker, Dr. Bruce Sands. I have had the pleasure of working closely with Bruce since I arrived at Mount Sinai back in 2017, and I am thrilled that you all will get a chance to learn from him today, just as I have even before I came to Mount Sinai, but especially since I arrived. Bruce was an Eagle Scout who did his undergraduate and medical training at Boston University, and then proceeded to the very prestigious internal medicine training program at the Hospital of the University of Pennsylvania, after which he went up north again to Massachusetts General Hospital, where he completed his GI fellowship training and research, did additional research, picking up a master's as well while he was in Boston, and he remained there until 2010, when he was recruited here to Mount Sinai to become the Burrill Crohn Professor of Gastroenterology and the Chief of Gastroenterology at Mount Sinai Hospital, expanding his leadership to the system level as the Mount Sinai Health System formed, and becoming the Director of the Digestive Disease Institute a few years ago. Bruce has an international reputation as a true leader in the field of inflammatory bowel disease, having published over 200 manuscripts, including 3 trials that those of you who cuddle up with the New England Journal of Medicine every night will recognize, the Accent 2, UNIFI, and Varsity studies that were published in its pages. He served as an associate editor of Gastroenterology, our primary journal in the field, and was a former chair of the Immunology, Microbiology, and Inflammatory Bowel Disease section of the American Gastroenterology Association. But in addition to being a clinical powerhouse and a research powerhouse in GI, I think it's important to recognize that Dr. Sands is an example for all of us in gastroenterology by the way that he cares for his patients. And he's been recognized in multiple ways for this, including being named the Humanitarian of the Year by the Crohn's and Colitis Foundation of America, the New England chapter, in 2006, being given the highest honor from the CCFA in 2016, the Henry D. Janowitz Lifetime Achievement Award, for which the Division of Gastroenterology at Mount Sinai Hospital is named for Dr. Janowitz. And in 2020, just this past year, Dr. Sands was named a Cullman Family Award winner for a patient communication. So it's with that context that I introduced to you today's Grand Round speaker, as I said, a true powerhouse in gastroenterology, but also here at Mount Sinai, Dr. Bruce Sands. Dr. Sands, take it away.
Wow, what a generous and expansive introduction. Thank you, Mike. It's really my pleasure to be here, albeit virtually, someday live again. And it is a pleasure to give a talk about advances in IBD, given that so much of the history of IBD is tied up with Mount Sinai. This is more of a general talk, not just about the management of IBD, which for the most part isn't really what you need if you're a primary care specialist, primary care provider. Here are a number of disclosures. I've had the good fortune of being able to advise many companies with novel agents to help them develop their drugs. And so in the next 45, 50 minutes, I'll take you through the epidemiology, presentation, pathophysiology, and evaluation of patients with IBD, talk about current medical approaches, and introduce you to future directions of medical therapy. So first, we have to understand what we're talking about. The first time that I visited Japan and gave a talk there, there were patient education materials in the back of the room. And I opened up the materials and I couldn't really understand what I was reading. I don't understand Japanese, but I could see in English one word Crohn and one word clone. And this is a kind of a comic depiction of the difference between, on the right is Dolly the clone, Dolly the sheep, the first cloned mammal, and the left is supposed to be Dr. Burrill Crohn, because I guess the C, the R and the L is confusing in the Japanese language. But I know you won't make that error, and you understand that there are 2 major forms of inflammatory bowel disease, Crohn's disease and ulcerative colitis, and we recognize that they have somewhat different signs and symptoms at presentation. Crohn's disease is known more for abdominal pain as well as diarrhea, less so for bleeding, and can have a number of complications such as perianal fistula, which may be present on as many as 16% of patients at presentation. And ulcerative colitis, on the other hand, may more likely present with bleeding, blood in the stool, as well as diarrhea, less commonly abdominal pain. In fact, I worry if someone is labeled as having ulcerative colitis and they have constant abdominal pain, it's typically just more cramping before and relieved by a bowel movement. And you should not see perianal fistulas in a patient with ulcerative colitis. So these are the two major forms of IBD. There are, of course, minor forms of IBD, microscopic colitis, that I won't really touch upon. We in gastroenterology are animals of endoscopy. We're very visual and in some ways very primitive. And so I can't give a talk in gastroenterology, topic in GI, without showing you endoscopic appearances that are typical of these diseases. So this is ulcerative colitis. You can see on the upper left-hand side what appears to be normal glistening bowel mucosa. This is colonic mucosa. You see the capillary pattern shining through. It's lightly pink, looks fine. There may in fact be a little bit of a scar, a pale area from a prior biopsy, but otherwise it's normal. And then mild inflammation, you can see there's a bit more erythema. The vascular pattern is obscured by the mucosal inflammation. And then once we get to moderate disease in the lower left-hand corner, you begin to see breakdown of the mucosa and ulceration. There's edema. You can no longer see the vascular pattern. And on the lower right-hand side, this is severe disease. There's extensive ulceration. There's spontaneous bleeding. There's inflammatory exudate that is ongoing there. And this is commonly what we see. Now, the appearance endoscopically for Crohn's disease is not always very distinct from ulcerative colitis. This happens to be kind of a classic case of severe Crohn's colitis. And here you see what is called cobblestoning. Cobblestoning is the fact that you can see both circumferential and longitudinal ulceration. And by virtue of the patchiness of the inflammation, you get islands of edematous mucosa in between, giving this bumpy appearance that is known as cobblestoning. But you really don't have to see cobblestoning, and it's really not pathognomonic for Crohn's disease. And in fact, it can be very difficult to distinguish Crohn's disease from ulcerative colitis that involves only the colon, namely Crohn's colitis. And there is a spectrum of IBD that includes what used to be called indeterminate IBD, but is now labeled IBD undetermined. And that represents somewhere between 5 and 15% of patients with colonic inflammation that can't easily be distinguished between UC and Crohn's disease. Now, you may ask, why does it matter? The diseases actually are quite similar in their pathophysiology, although not identical. And a lot of the treatments happen to be the same. But when it comes to needing surgery, say for severe disease, if you do surgery on a patient with Crohn's disease and thinking that it's ulcerative colitis and you create a J pouch, the course may be much more complicated. So eventually it can matter. There is a fair bit of diagnostic misclassification of patients with presumed IBD. In one study from 20 years ago, about 6% of patients had a change of diagnosis over time. 51% who had a change originally were thought to have UC and were then later diagnosis converted to Crohn's. 32% originally were thought to be Crohn's and later thought to be UC, and 17% were IBDU who later declared themselves one way or another. So you can see that the diagnosis is clinical in nature. There's no single test that is going to tell you if someone has Crohn's disease or ulcerative colitis, distinguishing them perfectly well from each other. It is still a clinical diagnosis. And there are many causes of colitis outside of IBD. In fact, I pride myself that in Schlesinger and Fortran some years ago, when I wrote the chapter on Crohn's disease, I had the longest, biggest table of differential diagnosis in the entire 2-volume set, which was the differential diagnosis for Crohn's disease. But some of the key things include the two diseases itself, radiation colitis, ischemic colitis, very important, especially in the elderly. Infectious colitis would be very common, NSAIDs, diversion colitis, diverticular colitis, and this is a very, very incomplete list. In the end, the colon is a pretty dumb organ. It only has so many ways of expressing displeasure, which is by inflammation. And it all looks the same visually. There are some items that are independently associated with the Crohn's disease diagnosis, as opposed to IBS, which is a much more common cause of abdominal pain and diarrhea, and is a much more common scenario in primary care than differentiating Crohn's disease from ulcerative colitis. For you, you should at least keep in the back of your mind that someone presenting with abnormal bowel function or abdominal pain might have Crohn's disease or ulcerative colitis. And here are some of the factors that might bring this to the front of your mind. Certainly, if someone had a perianal fistula or abscess or perianal lesions, such as big juicy skin tags, not just hemorrhoids, that should raise a red flag. People who have a family history of IBD, first degree relative, that should also raise a flag. Significant weight loss, chronic abdominal pain. Nocturnal diarrhea is a real tip-off for organic etiology of the diarrhea rather than functional. Fever, and no postprandial abdominal pain immediately after vegetables, and then finally no rectal urgency. These are red flags that tip off toward a Crohn's disease diagnosis, but they're imperfect. And then if there's one take home for you, if you're a primary care provider, it would be that every patient who presents with chronic abdominal pain or diarrhea should have a fecal calprotectin and a C-reactive protein. These two tests can really help you exclude the possibility of a patient having IBD to some degree of precision. And this is data from a meta-analysis showing that if a fecal calprotectin is measured and it's less than 40, there's less than 1% probability that the patient has IBD. And likewise, if a CRP is normal, less than 0.5, there's less than a 1% probability that the patient actually has IBD. So you can use these tests easily in your practice. Within the two diagnoses, we have different classification systems categorizing patients. And in Crohn's disease, we have the Montreal classification, which looks at age at diagnosis, location of the disease. Remember from med school that Crohn's disease can involve any part of the GI tract from mouth to anus, but most typically focuses on the distal small bowel and the proximal large bowel. But you certainly have patients who have exclusively small bowel disease, exclusively large bowel disease, some who have both, and some who may have typically only upper GI tract disease, although those represent a very small proportion of patients. Maybe most important is categorization of disease behavior. Patients present by and large with inflammatory disease, but in Crohn's disease, unlike in ulcerative colitis, they can progress to develop strictures, stenosing disease, or penetrating complications like abscess or fistula, and perianal disease. So just to again show you the visual, this is inflammatory disease. You see these ulcers. You also get a sense of the patchiness of the disease, more normal bowel mucosa surrounding abnormal ulcerated areas. And this is a representation. This is a barium study, which we hardly see anymore. This is fibrostenotic disease. You can see this string sign, a long area of narrowed bowel with edema surrounding that narrowing. Also probably a little bit of fistulization tracking in that right-hand arrow pointing downward, which is not uncommon intramurally in fibrostenotic disease. And finally, penetrating behavior, which is where fistulization occurs, because Crohn's disease, unlike ulcerative colitis, involves the full thickness of the bowel. Ulcerative colitis is just involving the mucosal surface. And because of the transmural nature of Crohn's disease, you can get penetrating behaviors, bowel to urinary bladder, bowel to anything, developing fistulization. There's mounting evidence that these forms of IBD, fistulizing or cicatrizing disease, are really molecularly distinct forms of the disease. And penetrating complications do respond less well, respond better, I should say, to early treatment with anti-TNF therapy, in contrast to cicatrizing disease, where there's stricturing behavior. That doesn't seem to respond very well to even early treatment with what may be our best therapy of anti-TNFs. Complicated disease behavior is also associated with distinct microbial populations, distinctly ruminococcus and stricturing disease and Veillonella and penetrating disease. And then if you look at expression array data, ileal genes controlling extracellular matrix production are associated with stricture, as you might imagine. So these are distinct forms of the disease, and more on the pathogenesis in a moment. But I think it's important to understand that IBD, and maybe especially Crohn's disease, can be thought of as a progressive condition. Clinically, patients manifest with flares and periods of wellness, which you see here depicted by this graph. And this could also be the inflammatory activity. This is an older model. The disease was thought to be episodic, and people were thought to be well in between. But in fact, what's really going on is long before the disease presents, there's a period of subclinical inflammation. And in fact, there can be a long delay in diagnosis, which is why I emphasized thinking at least about checking a CRP and a fecal calprotectin, maintaining an adequate index of suspicion to identify patients who have disease early so that we can intervene. Because over time, the longer time goes that the inflammatory process is unchecked, the more likely that you'll see these complicated disease behaviors, which ultimately lead to surgery, and in some cases lead to neoplastic complications, small bowel adenocarcinoma, or in large bowel disease, more commonly adenocarcinoma of the large bowel. And over time, you get deterioration of bowel function. So if we can identify disease early, we can intervene early and prevent these complications that are a consequence of accretional bowel damage. And the improved response, it results in improved longer-term outcomes. In ulcerative colitis, as I said, this is a disease of the mucosa. The extent is typically distal and then can range proximally to involve more and more of the colon, as much as the whole colon. And we also categorize severity as being remission, mild, moderate, or severe. You see how these are classified here. On the inpatient service, you'll typically see patients with severe disease who will have a distinct presentation that requires really aggressive therapy if the patient is going to avoid colectomy. And it's also important to remember that these are systemic conditions. They don't just affect the bowel, they affect the skin with things, associated conditions such as pyoderma gangrenosum, erythema nodosum, the eye, scleritis, episcleritis, and uveitis, bones and joints. You can get small and large joint arthropathies, axial arthropathies in association, certainly osteoporosis. Kidney, many patients with small bowel disease are susceptible to kidney stones. We can see rare cases of amyloidosis. You can see problems with the liver, such as PSC, in association with as many as 7 to 15% of people with ulcerative colitis, but also Crohn's disease, and a prothrombotic state in patients, especially with active disease. So just remember that these are not just bowel conditions, but affect the entire body. Now, a little bit about the epidemiology. These are diseases, by and large, that occur in the first world, not the third world so much. And you can see the highest instances are in North America and Western Europe, moderate instances in places like South Africa, Japan, Australia, although rising, and largely previously unknown in many parts of the world. But over time, and this is work done by a former fellow, Gil Kaplan, who's up in Calgary, he showed that over time, there's a rising incidence of both Crohn's disease and ulcerative colitis. If you start at the top and you proceed A through C for each of these diseases, you see rising incidence in many parts of the world, including China and India, and many places where these conditions were largely unrecognized. The incidence is really rising as industrialization occurs, changes in diet occur. It's really not known what the environmental factors precisely are, but the incidence is rising such that by the 2030s, this will be a global pandemic of its own. In the United States, if we look at the epidemiology in Rhode Island, as I did some years ago in an epidemiologic study in that state, we see what is typical of the age of incidence. You see that in Crohn's disease and in ulcerative colitis, the peak incidence is in the second decade of life. Some studies show a second peak, especially in ulcerative colitis, in the fifth decade of life, and that's unexplained. But these are typical results, and you also note that the disease can begin throughout the lifespan, much younger as well as much older. If you look at the incidence rates of Crohn's disease and ulcerative colitis, and for Crohn's disease and ulcerative colitis in Rhode Island, they reflect what goes on in the rest of the country. Age and sex adjusted rates are something like 13.9 out of 100,000 patients. So it's not public enemy number one necessarily. And yet, because people largely don't die of these conditions, the prevalence in the US is about 0.5%. Now we turn to the pathophysiology, and this remains a bit mysterious. On the left, you see the histology. What you may see are granulomas, collections of mononuclear cells in tight balls responding to we don't know what. This isn't TB, an identified infectious organism, although there is a unproven hypothesis that atypical mycobacteria may be the causative agent. This really has never fulfilled Koch's postulate. And on the right-hand side, we see inflammation and a very typical finding of a crypt abscess within a crypt within the large bowel. But you can see the inflammatory cells, mononuclear infiltrate, as well as neutrophils, attacking the submucosa here. And while this would be very normal in response to a pathogen like Salmonella, there's no identified pathogen in IBD. So the mystery is why this really occurs. You see normal bowel with this glacy goblet cell pattern, and you can see there is some inflammatory infiltrate in the normal healthy bowel, and that's in a state of readiness to fight off any enteric infections. But why does it go from this to a persistent state like this, where the mucosa is packed with inflammatory cells? Again, you see a crypt abscess on the lower left-hand side, and destruction of the crypt, really ulceration. So why does this occur? And for a long time, this mucosal inflammation has been understood to result from both environmental causes and genetic contributions. Some of the environmental factors epidemiologically that have been recognized is the role of smoking, particularly as a risk factor for Crohn's disease, but interestingly protective for ulcerative colitis. Ulcerative colitis is largely a disease of ex-smokers and non-smokers, and Crohn's disease more commonly a disease of smokers, although you do not have to smoke. And interestingly, appendectomy, if done for appendicitis, seems to be somewhat protective for ulcerative colitis, but does not really play a role in protection of Crohn's disease. These are still unexplained factors, but they cut distinctly for the two different forms of IBD. On the side of genetics, it's been understood for decades that monozygotic twins, especially in Crohn's disease, have a high rate of concordance, less so for ulcerative colitis. And for comparison to straight Mendelian genetic diseases like cystic fibrosis, where the risk is very high, it's much lower and yet still higher than what we would see for type 1 diabetes or for schizophrenia. Now, the first genetic locus that was identified as being strongly associated with Crohn's disease is very telling. This is the NOD2 or CARD15 gene. And basically, the LRR, leucine-rich repeat portion of this molecule, is essentially an intracellular sensor for bacteria. So when cells are invaded by bacteria, muramyl dipeptide, which is found in the cell wall of all bacteria, basically instigates inflammation. The left-hand side has CARD domains, which lead to activation of NF-kappa B, which activates downstream inflammation. And so the mutations, interestingly, are loss of function mutations in the leucine-rich repeat that leads to recognition of this muramyl dipeptide. It is still not completely understood how this results in inflammation that's ongoing in Crohn's disease, but it gives you a clear sense that the disease occurs in some way as an abnormal response to normal bacteria. Interestingly, knockout models do not develop Crohn's disease, and NOD2 deficiency in and of itself is not enough to develop ileitis. There have been, this is still an old slide, this time it was 163 confirmed loci, but now we're well over 200 confirmed risk loci. But I show the slide because what it shows you is that there is some commonality between Crohn's disease and ulcerative colitis. The majority of the risk loci are common between the two conditions, but also common with things like leprosy and susceptibility to mycobacteria and other immune-mediated diseases. There are some genes which are very distinctly Crohn's, for example, the NOD2 gene or PTPN22, and there's some loci that are distinctly UC. So the central challenge of autoimmune disease is that cellular heterogeneity is shaped by natural selection against microbes. And it isn't that we think that there's an undiagnosed mycobacterial infection in IBD, but rather the genetic architecture of IBD shaped in response to historically significant pathogens like TB. And in a new environment, a much cleaner environment, that genetic architecture confers an increased risk for IBD. So all of this points to the role of luminal flora in the etiology of IBD, and there's a lot of circumstantial evidence for this. Patients with IBD sometimes respond to antibiotics. An old surgery is bypass of bowel to treat Crohn's disease, diverting the luminal contents, including bacteria, away from the diseased portion of the bowel, and this was successful in the past, although no longer a part of therapy. Response to elemental diet alters the microbiota. Effects of probiotics have been observed here and there. It's well known that the lamina propria mononuclear cells that I showed you packing the mucosa respond to autologous gut bacteria, and there are antibodies present to numerous bacterial antigens. Also, in animal models of colitis, and there are multiple genetic models in mice and rats, typically, if you house these animals in germ-free environments, you do not see a manifestation of colitis. And the moment that you add even non-pathogenic bacteria is when you see the onset of the disease. So the bacteria are necessary, the genetics are not sufficient. And it's interesting that in some of these models, depending on what kind of bacteria you introduce into the model, you'll see different forms and manifestations of the disease. If you introduce into germ-free HLA-B27 transgenic rats, normal cecal bacteria without pathogens, you get an aggressive colitis. If you introduce just Bacteroides vulgatus, you get a moderately severe colitis. And if you introduce E. coli or cecal bacteria with a probiotic such as Lactobacillus GG, you'll see no colitis or protection. So all these things really strongly point to the role of bacteria. And finally, there have been many, many studies, this is an early study, but many since then, showing that IBD is a state of dysbiosis, that patients have very dysbiotic intestinal microbiome. We do not yet know how to repair that dysbiosis. And one of the fundamental questions is whether the dysbiosis is itself the beginning. Is it the chicken or is it the egg? Is it a result of the genetics and the inflammation, or is it the cause of the inflammation? And we still really do not know that for sure. So now we're going to turn to medical therapies. And as I was coming into my training in the early to mid 1990s, these were the only agents that we had. We had for Crohn's disease and ulcerative colitis 5-aminosalicylates. By the way, 5-ASAs really don't work for Crohn's disease, although they're widely used. Antibiotics were sometimes used for Crohn's disease. Steroids were used short-term for both diseases. And then we had immune modulators like 6-MP and azathioprine, methotrexate for Crohn's disease, cyclosporin for severe hospitalized UC. And while all these agents are still used, and I'll talk about them, there has been a revolution with the advent of biologic therapies. We'll talk first about 5-aminosalicylates because they really are adequate therapy for a good proportion of patients with mild to moderately severe ulcerative colitis. The grandfather compound is sulfasalazine, which was developed as a treatment for RA way back in the 1920s and 30s. And it was thought if you combine an anti-inflammatory ASA with an antibiotic, sulfapyridine, that this should be beneficial for this condition. But the key is that diazo bond in the middle, which essentially is a mechanism to protect the 5-ASA from absorption in the small bowel. And when the molecule arrives in the distal small bowel, proximal large bowel, the native bacteria actually cleave that diazo bond and release the 5-ASA, which has a topical effect as an anti-inflammatory. So when that was understood, since the sulfa was so problematic in terms of side effects, many different forms of the agent came along. You had diazobonded 2 5-ASAs called L-salazine, rarely used, valsalazide, which is binding the 5-ASA to an inert carrier, and then many forms of mesalamine, either given rectally as a suppository or an enema or a foam, and many forms of oral delivery with controlled release to protect it from small bowel absorption. These are great for mild to moderate UC. For induction of response, about half of patients will get there. For really remission, which should be the goal, it's more like 15 to 40%. And the safety profile is excellent. Really, there can be rare renal toxicity, namely interstitial nephritis. That requires a urinalysis to be done once a year if you use these medications. When patients fail that, especially in UC, but also in Crohn's, they may move on to corticosteroids. In fact, one of the earliest randomized controlled trials was done in 1955 by Truelove and Witt, looking at the role of cortisone as a treatment for severe UC. And back then, severe UC led to mortality in about 20 or 30% of patients. But with the advent of steroids, this was a game changer. Patients no longer often died of severe UC, and you can see the efficacy of this. So we still do use it as short-term treatment, but the problem is the moment that a patient is sick enough to need a steroid, their likelihood of needing a colectomy goes up to as much as 27% within a year for adults and 16% for children on average. And about 2/3 will respond, and many more patients will end up stuck and steroid dependent. So if you look at the short and long-term efficacy in UC, you can see complete remission in half, and this is on a population basis from data from the Mayo Clinic, partial remission in 1/3, no response in 16%, but at 1 year, you see prolonged response in just about 50%, about 1 in 5 to 1 in 4 is steroid dependent, and 29% have gone on to colectomy. And the data are not much different in Crohn's disease. And therefore, immune modulators were a very valuable agent when they were introduced in the late 1980s, and actually 6-MP was demonstrated to be effective by Dan Present and Bert Karlitz when they worked at Mount Sinai in those times. And these are effective maintenance agents. They help patients taper off of steroids, but the onset of response is very slow. The tolerance is not very good. I say 15% here, but it's probably more like 30%. Only half of patients are responsive, and there are issues of nausea, malaise. There's a lymphoma risk that I'll show you, infections, certainly herpes zoster, pancreatitis in as many as 7% of patients, and you have to monitor for myelosuppression. With methotrexate, which is used only really in Crohn's disease as a primary therapy, again, as steroid sparing most effectively, it can be used as an alternative to azathioprine or 6-MP. It can be effective given sub-Q or IM, but also PO to the extent that patients with small bowel disease do absorb it. It is also slow acting, but there are problems with nausea, teratogenicity in young women, hepatic fibrosis, and rare cases of interstitial pneumonitis. Now, with regard to the risk of lymphoma with thiopurines, we've understood this risk to be associated with the thiopurines, and one of the reasons that we use these agents less and less, although not very common. And you can see that as patients get older, the risk increases. Also, men are at higher risk than women in general. Fortunately, when you discontinue the treatment, the risk returns to baseline as if the patient had never received it. So often these, but not always, these will be EBV-related lymphomas that can revert, but many of these patients also have non-Hodgkin's lymphoma that is not EBV-related. So really, the revolution in therapy has been the biologics, starting with infliximab. And just as I was leaving my fellowship training and becoming an attending gastroenterologist, I was fortunate enough to be one of the first people in the world to use this agent in clinical trials. And this, as you know, is a monoclonal antibody. It is a chimeric antibody, meaning 25% of it is a murine component that you see in the FAB fragment up there in yellow, which means it's also immunogenic. And these are pictures, the likes of which we'd never seen before. This is from the cover of Gastroenterology in 1994. There were just a dozen patients treated with severe Crohn's disease refractory to other therapies. And you can see these rake ulcers down the barrel of the colon on the left-hand side before treatment. And then 4 weeks later, these ulcers are healed up. Now you might say results not typical, perhaps, but actually many patients do heal very quickly to anti-TNFs, and we had never seen anything like this before. This led to the approval of other TNF blockers like adalimumab, another monoclonal antibody, golimumab, yet another one, and these are human or humanized, but still antigenic, I should say, immunogenic. And then finally, an FAB fragment called certolizumab pegol that's pegylated to extend the half-life of it, which is humanized in sequence. And then subsequently, we had newer biologics, such as an anti-integrin antibody called vedolizumab that I'll describe, and an anti-IL-23 and IL-12 antibody called Ustekinumab. And these drugs have been approved over the last 20 years for various indications in Crohn's disease, in ulcerative colitis, in adult disease, and pediatric disease, and also, at least in the case of infliximab, for fistulizing Crohn's disease. Now, we know that at least in Crohn's disease, especially, the combination of infliximab with a thiopurine is more effective than either one of those treatments alone. And this is the work of my colleague at Mount Sinai, Jean-Frédéric Colombel, the SONIC study demonstrating superior clinical remission without steroids at 6 months. So we will often use combination therapy, especially up front. And why is this so? It's partly because the azathioprine alone boosts the levels, the drug levels of the infliximab, but it also has an effect of preventing antigenicity or preventing anti-drug antibodies to infliximab, which can occur. Now, the drug also works for ulcerative colitis, and this is a study that I had done in about a dozen patients just as I was at the end of my fellowship, hinted that infliximab worked for ulcerative colitis, but this study, these studies, Act 1 and Act 2, truly demonstrated that 2/3 of patients would get clinical response, about 1/3 of patients would achieve clinical remission of their ulcerative colitis in an 8-week period of time. The problem with anti-TNFs, in addition to their immunogenicity, is that they have a number of side effects. Now, the side effects are not as daunting as the side effects of steroids, I would say. While we do see serious infections, and they can be fatal, this is more easily demonstrated to be a risk with steroids than with anti-TNFs. But the issues are black box warnings for lymphoma, serious infection, malignancy, reactivation of hepatitis B and TB, so patients have to be checked for those things before they begin on therapy, skin cancer, both melanoma and non-melanoma skin cancers, psoriasis, paradoxically can occur, autoimmunity, meaning lupus-like syndrome, and immunogenicity we mentioned, and then we can see rare occurrences of demyelination, congestive heart failure exacerbation, and drug-induced liver injury, liver toxicity. With regard to the lymphoma risk, we already talked about that risk with thiopurines, but there is an increased risk when you combine thiopurines and TNF blockers, which I showed you is the preferred way of treating. If you do combination therapy, that actually produces an additive risk of 0.95 per 1,000 patient years. So if you do combination therapy for 10 years, multiply that risk by 10, and it ends up being something like 1% of people will have a lymphoma over 10 years of treatment. So for that reason, we will often do combination therapy in the first 6 months to 1 year when the risk of immunogenicity appears to be highest, but stop the combination, meaning stop the thiopurine after that period of time to reduce that lymphoma risk. But still, there are many patients who end up discontinuing anti-TNF therapy. They're not the be-all, end-all therapy for patients with IBD. Patients will lose response. There are some patients who have primary non-response altogether. They just don't respond to TNF blockade. And then some patients have to stop because of adverse events. And that means that we need other medications, and a few more have come along. The next biologic that came along was vedolizumab. And you may be familiar with natalizumab, which is approved for multiple sclerosis, also approved for Crohn's disease, but unfortunately is associated with progressive multifocal leukoencephalopathy because natalizumab blocks alpha-4 integrin, which affects CNS surveillance for the JC virus, which is the cause of PML. Now, to be more specific, vedolizumab blocks alpha-4 beta-7 exquisitely specifically, which means that it is only going to interfere with the interaction of that specific integrin, which is targeted to bind to MADCAM, which is found primarily in the intestinal microvessels. So really, this agent, vedolizumab, is very specific for bowel immunity and will not affect CNS surveillance. And in fact, there have been there's been one case of PML in many tens of thousands of patient years of use, and that patient happens to have been an HIV-infected patient, which is another well-known cause of PML. So how effective is vedolizumab? In ulcerative colitis, it's quite effective. You can see clinical response in the 6-week period in approaching half of patients compared to 25% on placebo, clinical remission superior to placebo, and mucosal healing also achieved significantly well. And you can see sustained outcomes. These are re-randomized responders. And over the course of a year, you can see ongoing clinical response, durable clinical response throughout that time, mucosal healing, durable clinical remission, and importantly, corticosteroid-free remission with this agent. Now, the drug seems to be a little bit more effective in the patients who have not had prior exposure to anti-TNFs, which suggests that this should be a first-line biologic therapy even before the use of anti-TNF therapy. And this was shown in the Varsity study published a little more than a year ago, which pitted adalimumab directly against vedolizumab in a blinded randomized controlled fashion and showed superiority of vedolizumab by 8.8% over adalimumab. And if you think that's a trivial difference, I would just tell you that the superiority of adalimumab over placebo is roughly that same effect size of about 8 or 9%. So this is a very significant effect. And most of the effect is seen in the anti-TNF naive patients, again, suggesting this is useful as a first-line biologic. In Crohn's disease, on the other hand, this had co-primary outcomes pre-specified at week 6, and it did not achieve clinical response, but did achieve superiority for clinical remission in that time frame. And you can see that, again, most of the benefit is in the patients without prior anti-TNF therapy, especially in Crohn's disease, at this early outcome. The maintenance effect, if you do respond, is again quite good, including clinical remission response and steroid-free remission. And as I indicated, because of the exquisite bowel specificity of this agent, it is a very safe agent. You see very rare, actually surprisingly rare, enteric infections like C. diff, but not much more than you would expect. And overall, we don't see cancer risk. We don't see systemic infections to any degree. It really seems to be a truly very safe agent. There are other agents that are attempting to also block lymphocyte trafficking, leukocyte trafficking. One of the ones that has been studied the most is etrolizumab, which blocks beta-7. So it'll block alpha-4 beta-7 as well as alpha-E beta-7. Alpha-E beta-7 is what brings in intraepithelial lymphocytes into the mucosa of the gut by binding to E-cadherin. And there have been a series of clinical trials demonstrating various levels of efficacy of this agent, and hopefully it will lead to approval. But another biologic altogether is directed at the role of IL-23. And here the genetics are an indicator, and you see the last author there is Judy Cho, who also is a scientist, the world's premier IBD geneticist, who now works at Mount Sinai for the last 7 years or so. And the IL-20, a polymorphism of the IL-23 receptor is found in common in both Crohn's disease and ulcerative colitis. And interestingly, there's a protective minor allele suggesting that if you can inhibit this pathway, you might have benefit therapeutically. Here's the whole group of therapies ranging from inhibitory to pro-inflammatory cytokines. And the relevant ones for inflammatory bowel disease are IL-23 and IL-12 on the left. You can see those two cytokines have in common the P40 molecule. So if you block P40, which is what the next drug I'll describe does, you will block both IL-12 and IL-23. I'll talk in a little bit about anti-P19 antibody, which blocks only IL-23. So that agent that is an anti-P40 antibody is Ustekinumab. And this looked at, in 2 different studies in parallel, the UNITI-1 study looked at TNF refractory patients, and you can see it was effective there as early as 3 weeks, separating from placebo. And in the TNF naive patients on the right, you can also see efficacy. And as you might expect, the TNF naive patients have higher rates of clinical response than the TNF refractory patients. The drug also demonstrates long-term maintenance effects. So if you re-randomize the responders at week 8 and give them ongoing treatment and compare that to placebo, you can see that whether you give the drug sub-Q every 8 weeks or every 12 weeks, and we give it clinically every 8 weeks, that's the approved regimen, you can see that the drug is effective at maintaining clinical remission. Now, only recently was it shown that Ustekinumab also works for ulcerative colitis, and this is the UNIFI study published a little more than a year ago, same issue as the Varsity study in the New England Journal. And you can see that for all these outcomes, clinical remission in both biologic naive and biologic failure patients, endoscopic improvement, clinical response, and even healing histologically, all these outcomes were achieved with Ustekinumab. And then the last novel agent, the most recent one approved now probably 2 or 3 years ago, involves an oral agent. We've talked about biologics, but now we're turning back to small molecule inhibitors of the immune pathways. And specifically, JAK inhibitors are coming to the fore in the treatment of IBD. So Janus kinases sit below the cell membrane surface in apposition to certain membrane receptors for various pro-inflammatory cytokines. When the cytokine binds to the receptor, the JAKs are activated and phosphorylate the receptors within the cell that are called STATs. And then these dimerize and they migrate into the cell nucleus where they invoke a pro-inflammatory cytokine response. So if you inhibit various JAK family members, you can inhibit that inflammatory response. And again, these are small molecule agents that can do this. The agent that is approved is tofacitinib. It's a pan-JAK inhibitor, but has a little bit more specificity for JAKs 1 and 3, which is a good profile for IBD for reasons that I won't go into. And you can see that even in TNF refractory patients that were included in this study, the drug was superior to placebo treatment. This effect size is only 10%, but this was a highly refractory group of patients. The drug is also capable of achieving at a higher rate mucosal healing in about 1/3 of patients, and also has a maintenance effect. There are a number of adverse events that are associated, including risk of herpes zoster. So we vaccinate all these patients with the recombinant vaccine, non-melanoma skin cancer. We don't see GI perforations. That is a concern because this blocks IL-6, and IL-6 inhibitors are associated with GI perforation, but we don't see that with this agent. And these patients do have an increase in total cholesterol, both LDL and HDL in proportion, so you need to follow that as well when you use these agents. And in the last few minutes, we'll talk about novel agents And you can see this cartoon from a paper by Ryan Ungaro and Jean-Fred Colombel in The Lancet from a few years ago. IBD pathogenesis is understood to be very complex, but there are a number of areas where therapy is targeted. First to the microbiome, such as with FMT or antibiotics, but also I mentioned already anti-leukocyte trafficking antibodies, not just vedolizumab, but etrolizumab and others that I won't detail further. We're looking at sphingosine 1-phosphate receptor modulators, such as ozanimod and etrasimod. This would be similar to fingolimod, which is used to treat multiple sclerosis. And these actually lead to internalization of sphingosine 1-phosphate receptors into the inside of the cell, which blinds them to a gradient that would normally lead them out of the lymph nodes and traps them in there. So it's inhibiting lymphocyte circulation. Then we have anti-IL-23 antibodies, specifically brazikumab, risankizumab, mirikizumab, and guselkumab. Half my job is learning how to pronounce these things, and a few other novel JAK inhibitors, such as filgotinib and upadacitinib, which seem to work both in UC and Crohn's, unlike tofacitinib, which only seem to work in UC. And finally, FMT and maybe antibiotics as well. A word about FMT. This is still in its infancy in terms of the science. There is a demonstration of some effect, but we are far from understanding how to maximize that effect. And we don't do this on a routine basis in clinical care unless a patient has refractory or recurrent C. diff. So in conclusion, we have a growing understanding of the pathogenesis of IBD, and biologic therapies have really increased the range of options for the treatment of IBD with improving outcomes. A number of anti-adhesion molecule approaches, as well as anti-cytokine approaches and anti-JAK approaches are being targeted as the next round of therapies. And we have a growing interest in the manipulation of the microbiome. But all these things are in development. You'll see many more novel agents in the next 2 or 3 years. So hopefully some of what I've told you is useful and interesting to you. And if we have a few minutes, I'd be very happy to take your questions. Thanks so much again for inviting me today.
Thank you, Dr. Sands. That was a great talk. We're gonna field some questions from the audience. Before you ask your question, just please introduce yourselves and say where you work, what kind of patients do you see?
I'm Norma Braun. I'm actually with the Pulmonary Critical Care Department, but of course, the whole body's still one, and each part seems to affect another. So a couple of things is, one is, because the cause of these diseases or the disease are rising in the world, is there more study on the study of the intake of diet to this disorder, and incredible degree of additives that are in prepared foods, and more people are eating prepared foods because it's quick and easy and satisfying. There's also a change in the diet from more fat, sugar, salt base to what we do now. So
yeah,
I want to explore that in more detail, because it's taking eating history is ignored in most research as well as clinical situations. The other is, are there any ethnic gender differences? The fact that is there fewer cases in Africa because they're parasites, or fewer cases in Africa because of different diet or they're starving? I mean, my mother used to say, and I was born in China, that every child should have a pound of dirt a day to stay healthy. So what is that interaction then between that environmental exposure and what's happening in modern society? I mean, this is fantastic.
You just about touched on every hypothesis about the etiology of these diseases. They're clearly not just genetic diseases. The genetic foundation is there, but with rising incidence in the developing world, it's very clear that there are environmental factors. It is extremely difficult to study the environment, right? The environment is everything around us. It's the air we breathe. In fact, I have myself conducted studies showing that certain forms of air pollution may be associated with Crohn's or colitis. It is the water we drink. It is food additives, which actually, some of which, like carrageenan and other gums, may kind of destroy the barrier function of the bowel that's normal. It's the composition of the foods that we eat. There's so many things, so many variables, and diet in particular is extremely difficult to study because diet is very varied, and it's very difficult to get at what the etiologies may be by the histories. So this is an active area of research. It is more than one more talk in itself. And all I can say is that there's intense interest in this. You also mentioned worms and things of the sort. The hygiene hypothesis is also predominant. All these things are out there, very difficult to sort out. And that's all I can say, really.
We have a question from Dr. Su. Put it on the chat. Like, he says, it seems gene replacement has come in and out of interest scientifically. Can you comment on this?
Gene replacement therapy, yeah. It would be hard to know. I mentioned that there are well over 200 susceptibility genes associated with IBD, each of which contribute in a very minute way to the risk. So I suspect that gene therapy will not be useful for most forms of IBD. On the other hand, there are recognized more traditional Mendelian genetic forms of IBD that are especially recognized in children, which can be cured through, for example, bone marrow transplant. And so there is a phenomenon of very early onset IBD, which is another studied entity, which seems to have a much more specific genetic etiology, and that might respond to gene therapy. But most people don't have that.
Dr. Ali from the Department of Rheumatology, if you have a question.
Hey, Yusuf.
Hi, Bruce. That was a great talk. Thank you very much. And amazing sort of audio visuals as well. Really great pictures. The question is, do you see much in terms of vascular complications in Crohn's or IBD? The reason I'm asking that, we just asked to see a consult up at Morningside in a patient with Crohn's who's had triple vessel disease, 43-year-old, aortic valve replacement, and she's got aortitis in her aorta. And apparently there is an association, we weren't aware of it. And how does that impact in terms of treatment, in particular with the new JAK inhibitors?
It's a great question. The most important vascular manifestation is actually venous thromboembolic disease. But we do also increasingly recognize that just as with other systemic inflammatory states, there is an increased risk of coronary artery disease for substantial ongoing inflammation of IBD. And also, there are patients, as you very well know and you just mentioned, there are patients who have vasculitides in association with either their IBD or as a complication of treatment with anti-TNFs, for example. So all these things can happen. The vasculitides are fortunately not really common and may just be, we see lots of immune-mediated conditions in parallel with the IBD, not necessarily caused by the IBD, but occurring in the same individual, maybe with similar underlying genetic etiologies, we don't know. The JAK inhibitors, really we only have one so far that's in use, and that's tofacitinib, which is only approved for ulcerative colitis. There are more coming. We have not, I can't say that I've used those specifically in patients who have vasculitis manifestations unless we need to get them off of an anti-TNF causing their vasculitis.
How do you advise patients on probiotics? It is so heavily marketed and everybody thinks that that'll fix it. And rather than in food, I find it amazing, but nevertheless, it's a huge market. So how do you advise patients? I'm
sort of agnostic about them. I say the proof that these will actually improve the course of your IBD is very scant. They're all different things. Probiotics are not just one thing. They're not one entity. If you feel better taking them, you may, but you're going to pay out of pocket for it. But I'm perfectly fine if you don't take it, and I don't routinely recommend that patients take them.
Any harm?
for the most part, we have not recognized any harm, but we also have not recognized any benefit.
Dr. Sands, thank you so much for a really wonderful review of obviously a very, very important disease state for many of our patients. And it's really wonderful to have you in the system and to have such expertise amongst us. Thank you for being with us today, and thank you all for joining us as well.